Good afternoon, everyone, and welcome to our webinar, Build Stronger Bones for a Healthier You. My name is Tony Brantley, and I'm a program coordinator with the Community Health and Wellness team at Suburban Hospital located in Bethesda, Maryland. We're thrilled to have you with us today for this important discussion. Throughout the presentation, we encourage you to submit any questions for our guest speaker using the Q&A box at the bottom of your screen. At the conclusion of the webinar, a short evaluation will appear. We would greatly appreciate your honest feedback as it helps us improve future programming. Please note that today's webinar is being recorded. The link to this webinar recording will be shared via email to everyone who registered within the coming days. Again, thank you all for being here. It is now my pleasure and honor to introduce our guest speaker, Dr. Qudsia Hussain. Dr. Qudsia Hussain is a board-certified endocrinologist at Sibley Memorial Hospital. She earned her medical degree from SUNY Downstate College of Medicine and completed an endocrinology fellowship at NYU Langone Medical Center. She also holds a Master of Public Health and Health Policy. Dr. Hussain is triple board certified in endocrinology, obesity medicine, and internal medicine. Her clinical interests include diabetes management, metabolic health, and hormone-related disorders. And she is passionate about helping patients achieve long-term wellness through evidence-based personalized care. Without further ado, I'm honored to present Dr. Qudsia Hussain.
Thank you, Tony, for that introduction and for having me today. I'm really excited to talk to you guys today about bone health and fracture prevention. So as Tony mentioned, I work inpatient as an endocrinologist at Sibley Memorial Hospital, where I see so many patients with fractures and untreated osteoporosis and undiagnosed osteoporosis. And so I feel very passionately about the subject. So I'm going to start off with a story that was published last month in the New York Times. So this is a story about a patient, Ronald Klein, who was biking around his neighborhood in North Wales, Pennsylvania in 2006, and he tried to jump a curb. But I was going too slow. I didn't have enough momentum, he recalled. As the bike toppled, he thrust out his left arm to break the fall. It didn't seem like a serious accident, yet I couldn't get up. At the emergency room, x-rays showed that he had fractured both his hip, which required surgical repair, and his shoulder. Dr. Klein, a dentist, went back to work in 3 weeks using a cane, and after about 6 months and plenty of physical therapy, he felt fine. But he wondered about the damage the fall had caused. A 52-year-old is not supposed to break a hip and a shoulder, he said at a follow-up visit with his orthopedist. I said maybe I should have a bone density scan. As he suspected, the test showed that he had developed osteoporosis, a progressive condition, increasingly sharp with age, that thins and weakens bones and can lead to serious fractures. Dr. Klein immediately began a drug regimen, and now 70 remains on one. So I wanted to include this story because, one, it emphasizes that a small fall can uncover hidden osteoporosis, but also that Robert Klein was his own advocate in asking for a bone density scan, which led to the early diagnosis of osteoporosis, treatment for it, and prevention of future fractures. So oftentimes you'll have to be your own advocate in getting the screening for osteoporosis, and we'll get further into that. So peak bone density is reached around 25 to 30 years old. And after age 60 and after menopause, bone density naturally declines. So you guys might probably heard the terms osteopenia and osteoporosis. I wanted to define them for you in a way that's very digestible. So osteopenia means that bone strength is lower than normal, but not yet in the osteoporosis range. And osteoporosis is when bones become thin and fragile, increasing the risk of fractures. And so I think of osteopenia as the warning zone and osteoporosis as the fracture zone. Osteoporosis, it exists in 10 million Americans greater than the age of 50, and 44 million Americans have low bone mass, so they're qualified as osteopenia. So this is a huge amount of Americans who live with these conditions. The lifetime risk of an osteoporotic fracture for a woman is 50%. which is huge. And half of all hip fractures are related to osteoporosis. So it's really important that we're talking about this today. And these numbers that I'm going to tell you about now were even surprising to me. You know, hip fractures are a significant cause of disability. 25 to 30% of people die within 1 year of a hip fracture. And a lot of other patients get, long-term disability or long prolonged hospital or nursing home stays due to hip fractures. And it's a silent disease, which I think makes it the most challenging. There's no symptoms unless a fracture is actually present. It's underdiagnosed in 69% of patients. And so a lot of primary care physicians tend to have, documentation, refills, or they're trying to treat illnesses that already exist. So a lot of times you have to be your own advocate, like Robert Klein was earlier in that story that I told you guys. So you have to sometimes, ask about your bone health and let your provider know if you've ever had a fracture before. Let them know what supplements you're taking for bone health. All of these questions become really important. So I remember in clinic, a lot of patients would ask me about osteoarthritis. So I wanted to distinguish between osteoarthritis and osteoporosis because the two are very different. So osteoarthritis occurs when cartilage wears down at joints and causes pain. So that's not something that a DEXA scan will pick up on. That's a completely different issue where you have joint pain, knee pain, sometimes shoulder pain. Arthritis can occur at any joint. Osteoporosis and osteopenia, on the other hand, tells us that bones are weak. It's looking at the quality of our bones and whether there is an increased risk of fracture based on the quality of the bone. So this is what a bone density DEXA scan looks like. It works by using a low dose X-ray to measure how much calcium and mineral is in your bones, showing how strong they are. So the diagnosis of osteoporosis, if you meet one of these four criteria, you automatically have the diagnosis. So the first one is having low bone density on a DEXA scan. And you don't need to know the numbers, but it's anything less than negative 2.5. The radiologist and your physician will read the bone density scan and let you know whether you fall into that range of having osteoporosis or osteopenia or if it's normal. Now, if you have osteopenia, which remember we said that was low bone mass, maybe not in the osteoporosis range, but low bone mass, and you've had a fragility fracture, that's also clinical osteoporosis. So what is a fragility fracture? That's when a bone breaks from something really small, like a bump that would normally not cause a bone break, or a cough, or bending down the wrong way. Small little things that happen that cause a bone break that normally wouldn't happen if you had normal bone density. And then if you have osteopenia and a high FRAX score. So a FRAX score is something that we calculate in office using age, sex, weight, health information, and it essentially just estimates your chance of breaking a bone in the next 10 years. So if you have a high risk of breaking a bone in the next 10 years and you have osteopenia, excuse me one second. Sorry, this sensor just turns the light off. But so if you have a high chance of breaking a bone in the next 10 years, or if you have, or if you've had a fragility fracture and you have osteopenia, that puts you in the osteoporosis category. Or if you've had one of these fragility fractures at the hip or spine, no matter what your bone mineral density is, you're still in the clinical osteoporosis range because we know that whether the bone density says your bones are weak or not, if you're having a fracture, major fracture at the hip or spine that's caused from, something small or nothing at all, then your bones are weak and need treatment. So who should be screened? All women age 65 and older, all men age 70 and older, and individuals who are at increased risk at any age. So let's look at who is at increased risk. So anyone who's had a fracture from a fall, from standing, or minimal trauma. Okay, so we're not talking about major car accident or standing on a ladder. We're talking about a trip and fall, or nothing at all, or a bend, or anything small. Individuals who have been on long-term steroids, so prednisone, hydrocortisone, dexamethasone for a long period of time, especially at higher doses. If you're underweight, sometimes you're not getting enough nutrition that supports the bone and bone health. Smoking, so smoking cigarettes, and excess alcohol use, more than 2 drinks a day, can often chip away at bone mineral density. Medical conditions or medications, we're going to talk about some of those. And early menopause, before age 45 is considered early menopause. The decline in estrogen leads to decreased bone mineral density. Any low estrogen state, actually, in females, and any low testosterone state in males can uh, lead to decrease in bone mineral density and bone health. And then a family history of having parents having major fractures. So, mom or dad with a major hip fracture or history of a spinal fracture. Good to tell your physician about that so they can screen you earlier than the recommended ages. So, what medical conditions? This is, I just wanted to throw these out there. They're more than this, but this is just to, give you the gist of why these medical conditions might cause low bone density. So there's some endocrine conditions. If you have really high thyroid hormones, your bone turnover increases, your bones are weak. Cushing's disease is a state where you have high cortisol production that affects the bones. These are some rare conditions. Hyperparathyroidism, that's a common one. Well, I shouldn't say common, 10% of women over the age of 70 will develop hyperparathyroidism. That's a gland that produces parathyroid hormone. And so the increase in the parathyroid hormone increases calcium, and the calcium gets taken from the bones. And so that can lead to osteoporosis, but your doctor will screen for that. Decreased estrogen or testosterone states, and then obviously anything that causes malabsorption, right? Anything that causes issues with calcium or vitamin D or magnesium absorption, like celiac disease, ulcerative colitis, gastric bypass, or really any digestive condition that causes you to have any issues with absorbing vitamins. Autoimmune conditions, so rheumatoid arthritis, lupus, especially if somebody's on steroids for these conditions. Chronic kidney disease is another one, or liver disease, because the metabolism of vitamin D gets interfered. Neurologic conditions such as stroke, Parkinson's, reduced mobility can cause bone health to decline. So if you have any of these conditions, it's good to talk to your primary care and ask them if you need a screening DEXA. These medications, so steroids I mentioned previously, those are a big one. Hormone suppressing cancer therapy. So, namely, these are aromatase inhibitors for patients who have had breast cancer, or androgen deprivation therapy for patients who have prostate cancer. Seizure medications, diabetes drugs, but specifically not all diabetes drugs, specifically pioglitazone. It can decrease bone mineral density over time. Proton pump inhibitors, you might have heard of, pantoprazole. They're usually prescribed for heartburn. They can reduce calcium absorption. Now, I'm not saying that you should avoid any of these medications, just that if you've been on them for a long period of time, it might be good to get your bone health evaluated. So we really want to focus on healthy habits and early prevention. So everyone should be optimizing lifestyle and nutrition to support strong bones. It's never too early and or too late to start. And so when you go to your doctor, they're going to talk to you, and if you bring it up about bone health, they'll talk to you about whether you need a bone density screen, but they'll also talk to you about possibly evaluating for secondary causes of osteoporosis. Sometimes it's just aging and bone decline or a family history, but other times there's sometimes a reason that somebody has osteoporosis, especially if the bone loss seems unusual for age or risk profile, like if it's before the age of 65 for women or at any age for men. We might screen for calcium, vitamin D, a parathyroid disorder. We might screen for testosterone, estrogen levels, just to make sure that everything looks good. The recommended amount of calcium for everyone is 1,000 milligrams daily. So in women over 50 and men over 70, the recommended amount is 1,200 milligrams daily. And this is including diet plus supplements. So I would say do not over supplement. If you feel like you're getting enough in your diet, that's completely fine. Supplements and dietary calcium are absorbed the same. One is not better than the other. Obviously, we always encourage patients to eat a really healthy, well-balanced diet. And if you can get it through the diet, great, but supplements work just fine. And I would consult with your doctor before initiating on any supplements, whether it's calcium, vitamin D, any supplements, because there are certain conditions like chronic kidney disease, or if you already have a calcium disorder, or if you have kidney stones, where these supplements might be titrated a little bit differently. So think 1,200 milligrams. And for the vitamin D, it's 1,000 to 2,000 units. And our goal vitamin D is 30 to 50. And so I will say many, patients get enough calcium. It's the vitamin D that we really don't get enough of. And especially many of us work inside and it's hard to get vitamin D. It's hard to obtain enough vitamin D from our diet. And a lot of patients will be surprised. And I'm actually not surprised. I'm usually surprised if the vitamin D is normal right off the bat because it tends to run low for a lot of individuals. You want to emphasize protein, leafy greens, dairy fortified foods. And so you might see something with orange juice with calcium and vitamin D. And I think that's better than just getting the orange juice itself if you aren't getting calcium and vitamin D in other ways and sunlight exposure. And we'll talk about some foods as well. So, why do we need calcium for bone health? Think of your bones as a calcium bank. And so, if you're not consuming enough calcium, the calcium levels in the blood drop, and calcium is released from the bone to keep other body systems running. And so, if you're not consuming enough calcium and you need calcium for body function, you basically are going to borrow it from the bone. And so, it's going to take it from the bone, your bones are going to get weaker, and it's going to release it into the bloodstream. And so we want to make sure that enough calcium is on board. There are dairy products such as milk and yogurt are excellent sources, but there are also a lot of good non-dairy options for those who are lactose intolerant or vegan. Almonds, so fortified cereal, fortified almond and soy milk, tofu, small bone and fish like sardines, and leafy green vegetables like kale and collard greens. So these are two calcium supplements, calcium carbonate and calcium citrate. These are the two we generally recommend for calcium supplementation. So calcium carbonate is essentially Tums. So sometimes we will actually just have patients take Tums because it is literally just calcium carbonate. But sometimes calcium carbonate for some folks causes some constipation or nausea. And if you're one of those individuals, then I would try calcium citrate, which tends to have less sort of stomach side effects, but tends to be a little bit pricier than calcium carbonate. Both are absorbed equally and they work effectively for supplementation. This is a chart of some high calcium foods. And on the left, there are things that are probably obvious to you that have calcium. And I want to point out how much calcium they have, because those are things we don't usually think about, right? So 8 ounces of low-fat plain yogurt has about 415 milligrams. Cheddar cheese, 306 milligrams. Non-fat milk, a glass of it, 8 ounces, 302 milligrams. Cottage cheese, mozzarella, around 300. So just one serving of any of those things completes a third of the recommended calcium intake amount. So then you really only have to account for 900 milligrams left. Or if you have two of these servings, then you really just have to account for about 300 left, right? And so fish, another thing that we don't think about is obviously there's calcium in dairy things, right? But for those who can't have dairy, there are other food options. And if you want to get it in naturally, sardines, tofu, salmon, chia seeds, beans, kidney beans, they all have good sources of calcium. And some calcium fortified products that are out there, again, like the orange juice, that's calcium and vitamin D fortified, or soy milk or breakfast cereals that have, or bread even. There's some fortified things out there. So if you feel like you're not getting enough in your diet, looking out for those labels, and they are, absorbed really well. Now, vitamin D rich foods kind of overlap with the calcium rich foods. So you got rainbow trout, salmon, canned tuna, mushrooms, egg yolks, milk. So a lot of these foods we don't often get a lot of. And so that's why vitamin D levels tend to run low. Again, the fortified foods and drinks are important. And so, besides calcium and vitamin D, which is what we commonly think of when we think of bone health, there are other nutrition factors that come into play. So, protein-rich foods are very important for strong bones. So, protein makes up about half of bone volume and is essential for replacing bone when it's lost. And so, I think everybody is always surprised to see how much is actually recommended. So, the recommended amount is 1 gram per kilogram per day. And this is in a healthy individual. So, not somebody who has chronic kidney disease where you have to have a little bit more of a protein restricted diet. Um, this is for the healthy individual, and you can always consult your doctor before make any changes in your calcium, vitamin D, or protein, just so you know that you're getting the right amount with your medical conditions and your kidney function and all of that. But the recommended amount is 1 gram per kilogram. So, if an individual is 180 pounds, let's say, that's about 80 kilograms. And if we do the math, that's 80 grams of protein a day, and many of us are not getting that intake in. And so, some protein-rich foods are Greek yogurt, salmon, beef, chicken, eggs, almonds, milk, lentils, tofu, leafy greens, fruits, nuts, and legumes. They're rich in magnesium and potassium, which can also support healthy bones. Okay, so you want to decrease risk factors that exist that chip away at bones, and that's smoking. Smoking is absolutely terrible. Over years, definitely individuals develop osteoporosis with long-term smoking. So smoking cessation is one. Limit caffeine consumption. That's something we don't always think about. I would say no more than 2 cups of coffee per day. Limit alcohol intake too, as that can affect your bones, especially if you already have a diagnosis of osteopenia or osteoporosis. And then of course, fall precautions. So when we say fall precautions, that means well-lit rooms, making sure that your rug is secured to the ground, making sure you're wearing comfortable shoes, you're avoiding inclement weather when it's possible. You're, just taking all the like if you have a walking assisted device, you're using it. All of the things that sort of make sure that we're setting, you up for to prevent falls, because falls are the number one cause of fractures, right? And so we want to prevent those. Now, the next point I want to make is about just stress the importance of exercise on bone health. What I think so many of us don't realize is bone is living tissue that actually responds to mechanical stress. And so a lot of times we think of, okay, we have these bones and they sort of just exist, right? But it's living tissue. And so when we engage in weight bearing and resistance exercise, it actually stimulates osteoblasts, which are bone forming cells through microstrain on bone tissue. And so every time you exercise and you're putting some stress on your bones are compensating by stimulating these bone forming cells. And so your bones are essentially like muscles, they're getting stronger. And so when you exercise, it increases or stabilizes bone mineral density, especially in the spine and in the hips, the areas that are most prone to fracture. It also, of course, exercise has many other benefits: posture, balance, muscle strength, and overall health. So, again, bone is very adaptive. It gets stronger with force, and weaker without it. And that's why when I was mentioning some of the risk factors, immobility is one of the risk factors for developing osteoporosis because if you're not using your bones, they're not getting stronger. So if you're new or have low bone density to start with, you want to start with low impact exercises. So that just looks like daily walking. Maybe you add in some light hand weights for upper body. And just half an hour most days is better. It's so half an hour most days is better than just doing weekends only. If you can get in, 20 to 30 minutes, consistency is better than just doing that one workout on the weekend. But obviously, anything is better than nothing. So if your bones are healthy, you want to choose cardio, so some sort of aerobic workout, but that adds impact. So maybe like running, jumping jacks, light jumping. It depends on sort of where your bones are, and I'll sort of include that too. Sports that move you in many directions, so dance, tennis, pickleball are great. But so if you have already been diagnosed with osteoporosis, always talk to your doctor first about a plan. They might refer you to a physical therapist so you don't get, there's no high impact exercises or you have proper form while you're doing them, no bending sharply forward from the waist, no quick twisting motions. Many hip fractures in patients who have osteoporosis happen before even a fall by twisting or just having weak bones. So definitely, if you've already been diagnosed with osteoporosis, I would talk to your doctor and come up with a exercise regimen that works for you. So you also want to build muscle to build bone. And I won't get into the physiology of it, but there are some myokines released from muscles that actually help your bones themselves. And more than that, if you are building your muscle, it's also supporting your bone as well. So strength training helps bones stay strong and prevents fractures. So even just light weights, resistant bands, Pilates is a good bone health workout, yoga, and strengthen muscles for daily activities. So you want to mimic motions that are functional for daily life. So lifting something, picking up something, lunges, mimic how you would get off the floor and you pick yourself up. So putting your arms down, different things that mimic everyday activities for functional health. And balance exercises are wonderful. So they reduce falls, which falls we know in patients with osteoporosis lead to fractures, or even in osteopenia or patients who are at high risk. So falls are a major cause of broken bones. We know this. And so balance exercises are great. So single leg stands. So even while you're brushing your teeth, you can try to do a single leg stand, stand on one foot. Just even small things you can incorporate into your day to day, maybe 5 minutes of yoga in the morning, some Pilates, Tai Chi, all of those are good for core strength and balance. So where to start? So as I mentioned, osteoporosis, if you have that, you probably want to start with a physical therapist who will guide you through some very safe workouts and make sure that your positioning is correct and you're executing the exercise properly. Osteopenia, if you have low bone mass, maybe a qualified trainer is a good place to start, especially if you have no if it's a completely brand new exercise for you. And if you're healthy with no fractures, there are some bone safe programs. There's some programs that are targeted for bone health. And if you can't find that, you could always ask whatever program that you are a part of, which wherever you go for classes, if they have something that's bone friendly, and they have probably been asked that question before and can guide you to some recommended programs or classes. So, excuse me. All right. So, exercise. So just to summarize, weight bearing, so strength training, hiking, walking, jogging, all great. Resistance training, I would recommend 2 to 3 times per week, even if it's for, 20 minutes, just getting that in. Because resistance training is actually one of the ones they've shown in studies to be the most osteogenic. And when I say osteogenic, I mean that is your bone builder. That'll help stimulate your bone cells to build more bone. Balance posture we talked about, and just functional movements again, pushing, pulling, squatting, all of the functions we use in real life. So I love this quote by Dr. Andrea Singer. She's the Chief Medical Officer of Bone Health and Osteoporosis Foundation. She says, people think of bone as the static thing, but it's a living, dynamic organ that is constantly remodeling. So that's a really big statement, right? As with your muscles, the more you strategically stress your bones with exercise, the stronger they become. And so, where does the role of medication come into play for osteoporosis? So, we know that lifestyle helps definitely in prevention, in progression, in osteoporosis for bone health. And here on the left, we see a healthy bone, and on the right, we see a porous bone, right? That's where osteoporosis gets its name from. But osteoporosis medications themselves reduce fracture risk. Okay. And we've seen that time and time again in studies. They slow bone breakdown, and some medications that they have now even build new bone. And when your bones, when you have osteoporosis, lifestyle changes alone just aren't enough. At this point, to prevent fractures, you may need medication. And so, how much do osteoporosis medications help? So, I could probably go through study after study after study showing the outcomes, but I didn't want to do that. I want to focus on just more so prevention and exercise. But I wanted to throw some numbers out there to give you an idea of how helpful these medications can be in osteoporosis. So, there was a large randomized controlled trials, and they did a meta-analysis, and they showed that osteoporosis medications reduce vertebral fractures, so that's spinal fractures, by approximately 50 to 70%. So that's huge. And then hip fractures by 40 to 50%. So these are really, really, really impressive numbers. And just to list are the medications that are out there. So, and some of you might be familiar with these medications. So, there are some we call bone protectors, and they're all the fancy name is anti-resorbatives, but they slow or stop bone breakdown. So this is usually where we start. And so that includes alendronate, which the brand names are in the parentheses. So the generic is alendronate, risendronate. Both of these are oral bisphosphonates. They've been around for a long time. And then there's an infusion called zoledronic acid. It's once a year. It's called Reclass. And then there's and that's also a bisphosphonate. Denosumab is a rank L inhibitor. It's a monoclonal antibody, works really well. It's an injection in the subcutaneous fat every 6 months, once every 6 months. And your doctor will sort of work with you, what your medical conditions are, what your bone density looks like, your kidney function to decide what the best medication is. You guys will decide together, if you have osteoporosis, what the best medication is to initiate. Now, some patients who have had, these fragility fractures and have severe osteoporosis, what we might do is start a bone building medication first. And bone building medications there's a limit of 1 to 2 years on them. And so it's a brief time you're on these bone building medications. And then after that, it's important not to just stop. Once you build the medication, it's kind of like braiding hair. If you let go, everything gets undone. So if you build the medication, you want to maintain it. So often after the bone building medications, then we switch to the bone protectors like the bisphosphonates or the Prolia to sort of maintain that bone health. Now, I wanted to draw attention to sort of the side effects and the sentiment about those. So this came out, this article in the New York Times in June of 2016, and I thought the title was pretty powerful. Fearing drugs, rare side effects, millions take their chances with osteoporosis. So I want to talk about the medication side effects and the risk of fracture. So without treatment, up to 1 in 2 women and 1 in 4 men over 50 will break a bone from osteoporosis. That is astronomical. That number is huge. 1 in 2, so 50% of women and 25% of men over 50 will break a bone from osteoporosis. So, and we know that hip and spine fractures can cause pain, disability, like I mentioned before, and loss of independence. Now, the serious medication side effects are extremely rare, and they include osteonecrosis of the jaw. And so that's necrosis, so breakdown of the jawbone, which is extremely rare, 1 in 10,000 to 100,000 per year. Atypical femur fracture, so that's 1 in 10,000 to 20,000 per year, and usually occurs after greater than 5 years of therapy. And that an atypical femur fracture, just to define that, is when you have a fracture because your outer thigh bone becomes too thick. And so we rarely see these. And especially if we are even concerned about osteonecrosis of the jaw, we generally have patients see a dentist before they start on osteoporosis medication to make sure that there's no dental infections that exist, or somebody does not need dental work that needs to be done, or there's no history of radiation to the jaw. And even if there is, we just have to be extra careful and mindful of it. And if patients have been on bisphosphonates for longer than 5 years, then we, reassess risk if they need to continue on it. So there's ways to also mitigate these extremely rare side effects. But the bottom line is the risk of a major fracture is hundreds of times higher than the risk of these rare side effects. So, where did this fear actually come from? So, early on, some doctors prescribed bisphosphonates too broadly. So, they would prescribe them for mild bone loss, osteopenia, and continued them longer than needed. So, some patients were on early, just below normal for bone mineral density on a DEXA scan. They got prescribed bisphosphonates and they were continued for 10, 15, 20 years. And so when patients started seeing some of these rare side effects and some of these lawsuits got highly publicized, that created fear and confusion, which really resulted in more than a 50% decline in bisphosphonates from 2008 to 2012. So there has been a huge change now. Today's guidelines use these medications very safely and effectively. We're more aware of all the side effects. We only prescribe them for osteoporosis or for clinical osteoporosis. We know that the fracture risk is really high, and we prevent any way we can of mitigating these rare side effects from happening. So once you start treatment, we generally get a bone density scan once a year. With Medicare, I believe they cover every 2 years, but the recommended is once a year. And you want to make sure you go to the same place to get the bone density scan, because it can be very user and reader dependent. So to track your bone density in the most accurate way, you want to go to the same place. Don't go to different sites, different locations, any of that. Try to go to the same place over and over again. And the same day, somebody who's borderline, osteoporosis can be diagnosed with osteopenia or osteoporosis with two different machines. You also, if you can get a hold of the scan, bring it to your doctor, because if you are seeing an endocrinologist or a rheumatologist, they could probably actually read your scan themselves. And then when you go for follow-up, they'll probably reassess fracture risk and then ask about any falls or fractures. So sometimes when life gets busy, we're thinking more about our primary care physician, but also if you're seeing a specialist for osteoporosis, make sure you mention to them if you have a fall or fracture, even if you if you don't have another appointment for another 10 months, let them know, and they might schedule you sooner to make sure that the treatment you're on is working. So, my key takeaways for stronger bones is get screened and know your numbers. A DEXA scan and a FRAX score can really identify risk before a fracture happens. You want to combine healthy habits for best results. So, calcium, vitamin D, protein, weight-bearing exercises, and balance training work together. The best results you'll get is from doing everything together. Treatments today are safe and effective, so medication risks are rare, but fractures are common and preventable. And talk to your healthcare provider about your bone health plan. Protect your strength, independence, and confidence. So I believe it's 1:40, so just 5 minutes early, but we have more time for questions, comments, anything.
Thank you, Dr. Hussain, for that very informative presentation. We will now transition to our question and answer period. Our first question comes from Barbara. She asks, why is the mortality rate so high after 1 year following a hip fracture?
That's a great question. So, a lot of times, immobilization after the fracture can lead to blood clots, decrease in activity levels. If you're not, moving around as well, sometimes it can cause progression of chronic conditions like blood pressure issues or diabetes. And so, infections from bed sores, because you can't, your mobility is decreased. So it's a lot of the complications of not being able to walk as freely.
Thank you, Dr. Hussain. Our next question, what are your thoughts on magnesium supplements?
I love that question. Okay, so if you have low magnesium levels, then you won't absorb calcium properly. And so if you go to your doctor and they check your magnesium and it's low, then they'll probably recommend magnesium supplementation for you. Now, if you have normal magnesium levels and you take magnesium, as long as you're, again, always consult with your doctor, but there are no studies that show that magnesium, it's a very important part of bone health, but it does not reduce risk of progression of from osteopenia to osteoporosis or prevention of fractures. Magnesium for some individuals can cause stomach upset and loose stools. So just be extra careful. But if you wanted to take magnesium glycinate, 200 milligrams is a perfectly safe dose to be taken. And there's no, as long as your doctor says it's okay, there's no downside in it. But there's just not good, robust data that actually helps bone health, even though we know magnesium is a big part of bone health.
Our next question, which form of calcium is best absorbed by the body? Plant-based raw calcium, calcium hydroxyapatite, hope I didn't butcher that, or calcium carbonate from limestone?
So I would say that the calcium we generally recommend is calcium carbonate and calcium citrate. Both of those are the ones that have been studied and show that they have equal to dietary absorption of calcium. So I'm not so familiar with the other formulations, but I would say that as long as you're getting the calcium, the grams of calcium that you need, that 1,200 milligrams from the supplementations, including multivitamins, by the way. So look at your multivitamin to see if how much calcium that has as well. But if you're somebody who's, plant-based, and then I think that there's no harm in taking that. I don't know that there have been studies looking at that particular those other formulations to see if the absorption is quite the same. But I know for sure the carbonate and citrate, they get absorbed well in the body.
Thank you. Our next question comes from Karen L., who asks, can osteopenia be reversed?
Yes, yes, it can. So anytime you have low bone mass, and it's a little bit less than normal, and especially if there's a reason for it. So if it's early menopause and you give a patient estrogen, or if it's a matter of low vitamin D, low calcium, you can certainly, supplement, reverse osteopenia. If you're exercising, you can build up your bones. Absolutely. I definitely think so. Osteoporosis, usually not so much because that means it's severely progressed in the other side. So you can stabilize it or keep it from getting worse. But generally with osteoporosis, the reason we recommend actual medication is because it's generally very difficult to reverse on its own.
Bob asks, osteopenia is diagnosed based on normal bone density. What is normal for a 40-year-old for my age?
Yeah, so osteopenia, so the question is whether for normal, what's normal bone density? Okay. So Anything less than negative, anything more negative than negative 2.5 is osteoporosis. Okay. And then anything between -1 and negative 2.5 is osteopenia.
And Dr. Hussain, I just want to, so it appears, I don't know if there's a correlation between the range and the age, because he was referring to himself. He said he's a 40-year-old. So I don't know if
Oh,
the
okay.
range
Yes.
correlates.
Yes, no, that's a great question because that matters a lot. So, actually, what they do is they take age stratified data, and so we go by Z score instead of T score if you're less than 50. And so, that is a whole. They base it on population data and men who are less than 50, what your bone health should be at that age. So, I don't know that data like offhand. But there is a whole it's based on your Z score, and the Z score is still like as long as it's more positive than -1, that's okay. But if your Z score is -1 to 2.5, that's still in the osteopenia range. And we say it's in the osteopenia range. Sometimes we treat differently, especially if you're 40. We definitely want to look at the secondary causes of osteoporosis, which is calcium, vitamin D, testosterone, thyroid. You want to look at your parathyroid hormones and make sure that there's not a secondary cause that's causing it. Or if you're take a look at your medication review and medical conditions and see if there's any place that we can target to improve bone health. Sometimes we'll treat if the fracture risk is high, but if the fracture risk is low and the bone density just shows that you could be on par with osteoporosis if you were if your age was higher, then we'll try to just mitigate the risks and reduce the risks first and target the etiology of why you're having low bone density before we even start any medication.
So, Dr. Hussain, we have several questions regarding specifically medication. What are the adverse effects of medications? I'm just going to read about three or four because they're kind of like grouped together. What are
Yeah.
the adverse effects of medications? What are the dangers of Prolia? Doesn't the benefit of Prolia reverse if and when treatment is stopped? And I'll just stop there.
Yes. So, Prolia specifically, which is denosumab, it's every 6 months. You cannot be late for that treatment. And I always stress this to patients, like if you're late for it constantly, then really it's not the best medication for you because the way that it works is it slows down bone breakdown, and over time it actually can increase bone buildup. But with Prolia, when you stop it, so if you stop it, you have to be switched to something else. Okay. So if you're on Prolia and your bone density is improving, then we'll often switch to a bisphosphonate before stopping it completely. Because if you stop it abruptly, for the first month, it actually increases fracture risk. And it also, if you stop it, it can reverse what the benefits it's done. Think of osteoporosis like any chronic condition, like high blood pressure, high cholesterol. If you abruptly stop the medication, things will get reversed. Chronic conditions need to be treated chronically, usually long term. There are some, there are in some patients, but it's case by case, right? So some patients, they're on Prolia for a while. You switch them to bisphosphonates, the bone density looks much better. And so what we do then is a drug holiday. And if the fracture risk is low, we actually stop the medication for a little while and see how you do off of it based on bone density and just falls and if you've had fractures, all of those things. And I'm sorry, the other question about the medication was, what are the side effects of Prolia?
Well, the first one was just a general question. What are the adverse effects of medications in general?
Okay, so I'm going to speak to the major ones. So that bisphosphonates are the number one prescribed medication for osteoporosis, and then it's generally where we start. So, 1 in 10,000, excuse me, 1 in 10,000 to 100,000 patients will have a osteonecrosis of the jaw. So that's decay of the bone jaw. I have personally never seen it. many endocrinologists have just never seen it because it's so rare. Generally, if that happens again, it's in patients with very poor dental hygiene or who need aggressive dental work or who have had radiation to the jaw before. Um, and we'll have them see an oral surgeon or a dentist if that concern is there before we even start. And then the other one is atypical femur fracture. Again, that's in 1 in 10,000 to 20,000 patients. And that's if you have been on bisphosphonates for over 5 years. So like if you've been on for 10 years, 5, 10 years, and generally after being on for 3 to 5 years, we reassess if you even need to continue it in the first place. We only continue if you're at high fracture risk and you can't be on another medication. But even then, I, again, haven't seen it. It's very rare. The risk of having a fracture again is 1 in 2 and 1 in 4 in patients with osteoporosis. So I would say that the fracture risk is much higher than any side effect that can occur. Now, some other side effects with bisphosphonates that people talk about less is sometimes you can get heartburn. So if you have severe heartburn, sometimes we won't do the oral bisphosphonates because you have to take them, when you're upright and so you take it with on upright and you have to stay that way for 30 minutes. You can't lie down. Otherwise it'll can cause irritation of the esophagus. And so you want to make sure that you're upright for half an hour. Now, if you have severe heartburn, I would opt for the IV infusion reclass, which is better tolerated. Um, the day of reclass, that's the IV infusion bisphosphonate. You can have like muscle, like kind of like you have the flu, like muscle cramps that day. So sometimes patients will take Tylenol the day of, but that doesn't last. And with Prolia, same thing, atypical femur fracture, osteonecrosis. So all of them tend to have the same sort of side effect profile. The only one that's different is Evenity. That's one of the bone builders, romosozumab. That's a very effective medication given once a month for 12 months. That one, in one study, they showed maybe a little bit of increased risk of heart disease and stroke, but then the other study showed that there was no increase in heart disease. And so the black box warning is still there. But again, that one's in one study, it didn't show any difference from placebo, so it could have just been an outlier. But I've had patients take all of these medications with really like very rarely ever having any sort of side effect.
Thank you, Dr. Hussain. Are the medications only for people who already have osteoporosis? Should people consider using these drugs as preventive therapy?
So for osteoporosis, I would say, but so remember that it's osteoporosis based on a low bone density score or osteopenia with a fragility fracture. So if you've had a fracture from some small trauma or minimal trauma or no trauma, then you should get started on these medications because you're more likely to have another fracture. If you have osteopenia, which is low bone mass, but you have a high FRAX score, so remember the FRAX score is the probability that you're going to have a fracture in the next 10 years, and the physicians usually calculate that. If that's very high and you already have low bone mass, I would recommend treatment. And the last one is having a fracture at the hip or spine that is, from minimal trauma, again, like compression fractures that they just pick up on a X-ray scan. Definitely those warrant treatment for sure because we want to make sure we prevent first fracture, but also if you've had a fracture, future fractures. As prevention and somebody has normal, healthy bones, the data is not there. And again, I think that's when people were seeing more adverse events of like side effects because they were just kept on for 5, 10 years, 15 years. We always weigh the risks and benefits. And I think if you're in the osteoporotic range, that's when you should, or in one of those ranges where you still have the diagnosis of clinical osteoporosis, I think that's the best time to start the medication.
Do you have more information about bone health in transplant recipient patients?
So, most transplant recipient patients are on steroids, and that's when things get really tricky. I think with chronic steroid use to prevent rejection of the transplant, a lot of patients can develop osteoporosis, and I do think those patients should have a bone density scan sooner. But also, there are medications that, as long as the kidney function is monitored, and as long as so bisphosphonates we don't give under a certain kidney function decline, but Prolia we do, and so we might opt for Prolia for those patients who have transplants. But also, if it's for kidney disease, end-stage kidney disease causes something called adynamic bone remodeling, and so oftentimes, those patients can have fragility fractures. In end-stage renal disease, it can be tricky to manage osteoporosis because many of the medications can't be given with patients who are on dialysis. But up to CKD stage 4, we can give Prolia as long as the calcium levels are monitored very closely.
Dr. Hussain, are you familiar with bioregulators or peptides to improve bone density?
Yes, yeah. So there is a lot of literature out there about peptides. I actually get asked about peptides very, very frequently. I know Joe Rogan had mentioned it in his podcast and people use it. I think the data out there right now, I wish we had better studies, and maybe that's part of the future studies that they're probably working on. Right now, we just don't have good evidence to say that it works for osteoporosis or it's beneficial for osteoporosis.
Okay, this next question is actually a series of questions. It looks like it's from the same person. They say they thought Prolia was bone building. Why not take Fosamax? And then they further say that Prolia side effects, infections, chronic pain, hospitalization. What is better for bone building?
What is, oh, so um, which medication is better for bone building? So abaloparatide, teriparatide, and romosozumab, those are the three medications that are bone builders. They're called anabolic medications. They help build up the bone, and they're usually only prescribed for 1 or 2 years. So in rat studies, the teriparatide and abaloparatide, so they're brand names are Forteo, which you might have heard of, and Timlos. They build up the bone, but they're not recommended for over 2 years because in rat studies they saw osteosarcoma, never in humans, and then they took the black box labeling off for the Forteo for you can use it over 2 years because they didn't find any evidence of any osteosarcoma in humans whatsoever. But they're usually bridge medication, so you build up the bone and then you start on the anti-resorptives or the bone maintenance medications like the bisphosphonate or the Prolia. Now, the reason you can't, everyone can't be on the bone builders first, they're not covered. You have to have severe osteoporosis or fractures to even get those bone builders first before the anti-resorptives. So that tends to be a little bit of a insurance issue. You most insurances will not allow for the bone builders before the anti-resorptives because they tend to be pricier medication, and we know that the medications like bisphosphonates and Prolia work, and so they want you to start there first, which isn't always a bad option because they do reduce fracture risk.
Our next question, should you take calcium and vitamin D and magnesium together?
Yes, you absolutely can. Yeah. I would say if you're on thyroid medication, of course, I'm going to say this as an endocrinologist, make sure you take the take it 4 hours apart from your levothyroxine if you're on thyroid medication, because it does interfere with absorption. But otherwise, yeah, calcium, magnesium, vitamin D can be taken together. Some people take magnesium at night to help them sleep. So I would say around dinner time is a good time because calcium and vitamin D get better absorbed with food. And so you probably want to take it also slightly closer to evening time. So I think dinner is a good time to take those supplements. And you could certainly take them together.
Thank you. So we're approaching the end of our session, so we'll take two more questions. One, do statins have any effect on bone health? And then the last question is Fosamax the same as the benefits of Prolia?
So Prolia is a little bit, so Fosamax helps to prevent vertebral fractures and also hip fractures. Prolia, also good for both. Um, Prolia tends to be a little bit better with this with decreasing vertebral fractures, so spinal fractures. Also, the thing with Prolia is it can be given at a declined reduced kidney function, whereas bisphosphonates can't. And so that's where Prolia sort of wins out over. And the other thing with Prolia is it's every 6 months versus taking alendronate once a week. Because remember, these oral tablets, so alendronate is once a week tablet. And the biggest problem we have with that is compliance. So just remembering to take it once a week. And resendronate, which is the other oral form of bisphosphonate, that's at once every month. But I would say efficacy-wise, they're both similar, with Prolia being better at the spine.
Thank you, Dr. Hussain, for sharing your expertise today, and thank you for everyone who joined us. Don't forget to please, you will see an evaluation at the end of this webinar. Please take time out to take it and offer your input, as it does help us with our programming. So again, have a great, wonderful rest of your afternoon, and thank you so much, Dr. Hussain. Have a
Of
great day, everybody.
course, thanks for the wonderful questions. Take care.